Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. We're doing a back-to-back early morning podcast on the weekend.
Yeah, I slept in today. I didn't do my workout before the podcast because
What?
I'm looking. Yeah, I know. It's crazy. It's crazy. I'm looking at some rides for later on, but it's gonna be a fun day. Like we mentioned before, it's one of the last weekends I'm in St. Louis fully for a while, so gonna cook again. Cooked again. Cooked yesterday. It was fantastic.
We are so different. I I definitely didn't get up early to work out, but we do have a hard end because I have to go lead a congenital journal club, which I'm super excited about. It's a way we connect with our residents and fellows and each month have a session and should be great.
Now you guys are doing it over coffee. You mentioned in your email that the cafe you used to go to isn't open early anymore.
Yeah, they changed their hours. They don't open till 8. And 8 o'clock's fine, except for it starts to get into the day. And I don't want this to be a burden and we're careful about making sure that everyone's in and there's no pressure to do this.
I remember fondly is the term I will use the journal club for my fellowship year, and I learned a ton. I clearly knew because I knew I was coming to WashU already as faculty that I would not be doing any congenital, but the passion that you and Lindley will have for that is amazing. It's contagious. It's one of the things I love about our program is that we all have our things pretty much and subspecialty stuff and we just pursue it and we love it and you just hope that the passion is contagious, which I think it is. Not necessarily like you're gonna go do congenital, but you're gonna really want to be into something like you and Lindley are into congenital, like I'm into nerve.
Yeah, it is an interesting sort of decision we have made because Lindley and I have had opportunities to set up a fellowship focused on the peds upper extremity. And we didn't want to do that because we value the our traditional hand fellowship, and we don't go looking for applicants that are all in on peds upper extremity. Obviously, we consider them like we consider everybody else because we want that someone who's interested in everything and eventually will hone in, which I think has worked well for us.
Yeah, I think it has. I think it's a great thing that our fellows get exposed to it. I mean, at this fellowship, you get exposed to pretty much everything you want to. That's possible under the sun in terms of hand and upper extremity. We're light on elbow, and we're very clear about that in our interviews. But aside from that, it's pretty awesome fellowship. And you get the great elbow OCD stuff with you though, elbow scopes. I saw more elbow scopes and wrist scopes during fellowship.
Yeah, we're light on, I guess, arthritic. I mean, advanced arthritic elbow is really all I would say. The soft tissue management around the elbow, the adolescent elbow, the young adult elbow, um, some ligament. But you're right, we don't have that. We don't do total elbows, for example. But everything else, you're right. I didn't used to be able to say that, right? I mean, we used to have when I first started, we didn't have great plexus and we didn't have great soft tissue coverage. So it's been fun to watch.
Yeah, absolutely. And that's obviously the elbow thing is the byproduct of having probably one of the best shoulder and elbow services in the country next to
Yep.
us.
Yeah.
So that certainly is impacts it. But yes, our program has changed even in the last 7 years that I've been practicing.
Yeah, well, what's interesting is that our topic for today, which we won't mention quite yet, just to build the excitement. I feel like we need some sounds going on, like all the good podcasts, or
Yeah,
at
we
least
we need
expensive
we
to
need
voice.
lasers.
Yeah, like zooming us in and out. But our topic for later is definitely a general hand surgeon topic. But the beauty is, you and I love this stuff. Like, it's not like, even though we both have our specialties, I still love bread and butter hand, as I call
Yeah, every now and then I'll get asked if I want a purely nerve practice, and I don't think I do. It's just, first off, it's educationally, it's not as great for the trainees, but I also love this stuff. I love being the general hand surgeon. Now, could probably get a little more selective about the stuff I will and will not see. But and maybe you can share some insight into how your practice, your selection criteria for your scheduling has changed over time. But overall, I love the general hand stuff. I love the trauma. It's all good.
Yeah. No, I think ultimately time will do that to you, right? I mean, you just won't have time to do everything you want to do, and you're probably already there. But I tried to change my practice a bit by saying I wouldn't see patients over the age of 45. Um, and that does fundamentally change your practice. I do fewer triggers and fewer carpal tunnels, not zero, fewer CMCs. But the reality is, I also am a pushover, and patients I've seen before, if they want to come back, obviously I let them, and direct referrals and patient, so it's just a random person who calls WashU and says, "Hey, I need a doctor for my carpal tunnel. I'm 73." The way our system works is our schedulers kind of find the first available. And when they see I'm the first available, if that happens, then they just skip me, which I think is great. It helps others build their practice too.
Yes, I've been the recipient of many patients who say, "Yeah, Dr. Goldfarb is only seeing children now." It's like, right, right. Yes, that's what we're going with now.
Yes, yes,
I'm too old to see Dr. Goldfarb. Okay, cool.
I love it. We we as everyone knows, we appreciate our audience, and we really do. It remains the fuel that helps us. We are trying to gather more information, so if you look in the show notes, there's a request to complete a new survey. We are asking for new reviews, because that helps us build our brand, and we're still planning, not hoping, planning on doing a giveaway of Chris's signed textbooks. So lots out there for you guys.
Or one of Chuck's many signed textbooks. Thank you for doing the survey. Don't want to belabor it too much, but it is really important to us. And then also the reviews are helpful. I like hearing nice things about Chuck. So please feel free to write those and ask questions in the reviews as well, and we'll make sure to answer them. Have you had any interesting cases recently?
I have. I don't have much detail to go into, but I'll say a patient who travels from overseas, great family. I saw them when they were quite young, and made the diagnosis of ulnar deficiency. And so I don't want to get into the weeds in congenital too much, but I tried something which I've done before with some success, not perfect success. This patient had when you have severe ulnar deficiency, you can have a fusion between the radius and the humerus. And sometimes those patients still have a well-formed ulna at the elbow. So theoretically, if you didn't have that bony fusion, you could regain elbow motion. With the bony fusion, your elbows are where they are. And so with this patient, we took down the synostosis between the radius and the ulna, interposed tissue, and initially had regained some really good motion. And over time, unfortunately, bone reformed, which I can't say it's 100% unexpected, and it's certainly a risk we talked about, but disappointing. Well, the patient came back years later. And what's interesting is the diagnosis was only partially correct. I think the patient actually has a multiple synostosis syndrome, which is not something I've encountered a great deal, but there are lower extremity issues at the foot level. There are symphalangism issues at the hand where the joints didn't form, and so the fingers don't bend, all the joints don't bend in the finger. And so I think that makes me feel a little bit better about why the bone reformed. So just super interesting. We did some genetic testing, super interesting. I'll close by saying, her elbows were essentially fused in a straight position. And that's difficult for a couple of reasons. One, you can't feed yourself easily or at all. Personal hygiene is easy, toileting is easy, but can't feed yourself. And as your arms grow longer, your hands get further and further from your face and from the ability to eat. And so we did a surgery where we bent one of the elbows, and it was tough, a lot of scarring. And we, had to shorten and also flex through the bone. And surgery technically went well, but it's a very unusual and interesting, and I think successful surgery. But it'll be something we have to watch over time because she's not done growing and her arms will grow away further. So really interesting stuff for me.
Interesting case. Never heard of something like that, even through all the congenital journal clubs I went to. Probably heard about it and forgot about it, but at least I learned it at some point. How do you make an elbow joint without making a joint?
So in the first, when we treated this child as young, and one of my principles is I believe that if you're going to try to do something where you restore motion or improve motion, the earlier you do it, the better, because there's so much remodeling potential in the young child. And so 6 months of age or sometimes even younger, to me makes a lot of sense. And we do that with the other condition. We do that, and again, we're getting in the weeds, but is with ulnar diamelia, otherwise known as mirror hand, where some kids are born with two ulnar bones, and so they don't have good elbow motion. Same idea, early intervention. For this case, there was an ulnar humeral joint. It just couldn't develop and function because the radiohumeral synostosis. So
Got
taking
it. So
away the radiohumeral
you take down radiohumeral synostosis and allow the only humeral joint to move. Is that correct?
to move. And the muscles
Excellent.
aren't perfect, but even if you just get passive motion, our therapist listeners will appreciate this. Even if you just get passive motion, that's dramatically better than having no motion.
Well, and especially, in the era of, active assist devices that are going to be much more helpful. That's something that when this patient comes to be an adult, there's probably going to be some technology that's going to help her.
Absolutely. That's exactly right. And we watch children with arthrogryposis where they usually don't have active motion. And if we can restore some passive motion, the function is incredible. Watching kids adapt is really remarkable. So cool case, challenging technically, intraoperatively, ultimately great outcome. But we should switch to some bread and butter.
Well, we should, but I actually want to ask you a question about practice management. So if you have somebody coming internationally, first off, how long did it take you to develop that aspect of your practice? When did people start seeking you out like that? And then how do you manage that? Do they contact you directly? How do they arrange travel? How often do they come back? What's done locally? What's done overseas? And you know, I know that you're a surgeon to the stars, but in all
Uh,
seriousness, we at our practice we have had patients coming from all over the world to have spine surgery here, have hip scopes here, for example, and apparently congenital hand surgery here.
Yes. So it is a increasing, I guess I would say, opportunity, which I very much enjoy. I tend to deal with most of it myself. Patients find me. It's been different things. My blog is one resource for patients, that's why I write it for congenital anomalies. So patients and families have a knowledge source, but some of them reach out for more. Um, and I've done it. Initially, I was just FaceTiming, saying hi, and kind of learning a little bit. But recently, I've tried to make it a little more standardized and use some of the consulting services that are online. The one I've used, and I have no vested interest. I think they do a good job. It's actually from your residency institution. It's called BICMD. And I actually was writing an email to a patient before we got on. And BICMD allows you to do teleconsultations, which are really just educational opportunities for the family, and that's why it's legal. And they handle all the details. And so I've used that. I always offer patients the opportunity to come to St. Louis, and many do. The finances are where it gets tricky, right? Certainly you'll have some well off, and then you'll have some not so well off families. And I will say it simply, our institution doesn't make it super easy, um, either to do the teleconsultations or to deal with the payment issues. So it's tricky. I do use the Shriners Hospital for this with kids because it takes that issue off the table.
Right, right. And we've had Ben Machukwu on the podcast in the past. He was talking about his NBA bubble experience, but Ben's been the driving force with Riley Williams up at HSS for this BICMD juncture. I don't know what you call it.
Service.
Service, yeah. So, but yeah, so people should check that out if they're interested in developing that part of it. I thought that was interesting. So, bread and butter. I've had some interesting cases recently that I wanted to bend your ear about. So, how do you think about the MP joint in the patient with advanced thumb CMC arthritis?
Should we should have gotten Macy on, but should we talk about, let's talk a little bit about what you look for in the clinic first, if that's okay, in a patient. And I'll tell you how I think about it, whether it's exactly correct biomechanically or not, I don't know. But when a patient comes in, and let's do the stereotypical advanced CMC arthritis patient. So we'll go back to that 73-year-old I mentioned earlier. 73-year-old female who has severe CMC arthritis. How do you think about that patient? What does your examination look like? How are you better understanding what the thumb is able to do in this previously untreated patient?
First thought is usually, gosh, I guess I know why this patient didn't go to Gold Farb. Second thought is, can we find a way to not do surgery? Usually, honestly, that's my default for thumb CMC. And as I've become more experienced with, just surgery in general, I think that I try to minimize surgery if we can on certain patients. And some patients just really want to get at it and do it. Other people are going to be a little slow to recover, so to say. So I'm very honest about the conversation with them about how long it takes to get over this surgery. And we've talked about that paper we've written in the past about how long it takes. And it takes longer than everybody wants. And that sometimes scares people away, to be very honest with you. You don't want to scare them, but you do have to be honest. And then in terms of looking at the thumb itself, sometimes you can tell when they've got that really flexed metacarpal head and that tipped over deformity, and then you start to see the Z deformity happen at the MP joint. And one of the things I always try to dictate and also talk to our residents and fellows about is what's going on with the MP joint. Did you look at the MP joint, before we indicate this patient for surgery? Because once you start to see some extension posturing, I guess I'll call it, at the MP joint, then I start to get worried about, if we address only the CMC joint, what's going to happen to the MP joint? Are we going to potentially worsen the deformity?
Yeah. So I agree with everything you said. I guess I'll add a little more flavor, or I guess my perspective. So when I think about severe CMC arthritis, the base of the metacarpal subluxates dorsally, almost always. That's the pattern of the arthritis that develops.
Is that
Um,
because of the so-called beak ligament is intact and is pulling or
there's been
allowing it to escape? What do you believe that, or do we believe Amy Ladd's newer work showing that, it's not the beak ligament that matters as much?
I'm not sure it's the beak ligament. That just doesn't make enough sense. I do think there are obviously reasons that women develop arthritis more than men at this joint, although it's obviously not exclusive. I don't know that I understand it, and I'm happy there are people like Amy Ladd that like to delve into the why. The what is, as that metacarpal subluxates dorsally, what tends to happen is the thumb also adducts and is drawn towards the index metacarpal. So that creates its own set of problems. And the way I try to keep things simple, and tell me, you're going to laugh at me probably, but the way I think about it is all of a sudden you have a thumb that is adducted. And we're showing this for YouTube, if you try to then grab that soda can with the adducted thumb, you can't get the soda can in there. And so patients that have at least some degree of laxity will break at the MP joint. They'll hyperextend at the MP joint. So the metacarpal, instead of being straight, is now tilted. So the base of the metacarpal is up, the head is down, and you can get the Z deformity where the proximal phalanx then hyperextends at the MP joint. And so you get this MP instability because of your CMC instability, which allows patients to sort of function while their arthritis is progressing.
Yeah, I think about it similarly, but I think that the way you described it is perfect. What happens if you don't address the MP joint? Is you just say you do your standard CMC surgery, whether that's a suture suspension like Genie Del Signore, or it's a LRTI, Burton Pellegrini, or your expensive suture tape suspension.
Well, one thing is clear. If you don't address it, even if you help the pain, and you will help the pain at the CMC joint, most patients will not be happy. That is it can be a significant deformity. So I think one way or another, you have to address it. And you should start with therapy. I think if some patients, if it's not too advanced arthritis, but let's say it's a ligamentous lax patient, their arthritis isn't terrible, then I think you start, as Macy has informed us on this before, you should start with therapy and try to help with the position of the CMC joint, therefore the position of the MP joint, and maybe, just maybe, you can minimize this problem. But if you go to surgery,
Well, hold on a second. I do like I agree with you entirely, and our therapy colleagues are invaluable for that particular issue. And I like an MP joint custom orthosis at times to really get the MP joint into at least neutral or some flexion, to see if you can control that. Um, are there what's your threshold to address the MP joint in surgery versus just doing a thumb CMC? So say you've gotten some reasonable improvement with therapy of the position of the MP joint. Are you done just doing your standard CMC surgery, or do you do anything differently in that surgery too?
Um, I guess first question is threshold. The literature would tell us 30 degrees of hyperextension. I think that's an arbitrary number. It's just as good a number as anything else. But like most of our criteria in orthopedic surgery, I don't think that's a a line that cannot be considered. But it's a good play. It's a good number to have in your head to understand whether you should think about it. But here's how I think about it. And I think I learned this doing CMC fusions, because when you fuse the CMC joint, you realign the joint. And when you realign the joint, it is not uncommon that you also take care of the MP joint as well. And so when I do soft tissue reconstructions, whether that's an LRTI or whether that's an internal brace, there are different ways to assure that you bring the base of the metacarpal back down. And when you bring the base of the metacarpal back down, if your soft tissue contractures aren't too severe, your MP joint will then assume a normal posture and you can skip intervening there. That's how I think about it.
Got it. So then how do you bring the MP joint or the CMC, the base of the thumb metacarpal, I should say, back down? How are you adjusting your technique? Is it a tensioning thing? Is it where you're putting, if you're doing an LRTI, is it where you put the tunnel? If you're doing a suture tape suspension, is it, how you, where you put those anchors? How do you do it?
Yeah, the two operations I do are easy for me to talk about. I don't do other operations, but for the two I do, I think that for the suture tape suspension plasty, which I continue to enjoy, I think it's a good operation. We're classically taught to create essentially a suspension bridge for the base of the thumb metacarpal. And you do that by putting an anchor into the radial base of the metacarpal and an anchor into the radial base of the index metacarpal, and you have a sling. The problem is the base of the metacarpal can go sort of where it wants, supported by that sling. So I add a third leg to that when I'm worried about this, and essentially put a heavy needle through the dorsal base of the metacarpal and then pull it down. And so by doing that third kind of not anchor, just putting the suture tape through the dorsal base of the metacarpal and then tying it onto itself, you essentially bring the base of the metacarpal down, bring the head of the metacarpal up, and it addresses the MP joint. And it's just
So before you go further, let me just
rehash,
summarize that. Yeah, and just
clarify.
make sure that, yeah. So you've set your proximal distal kind of distraction, right, with the suture tape, and you've already set that.
Exactly.
So now you're then taking, so after you've got your anchors in and your suture tape is in, you've got the free portion of the suture tape.
And for me,
Then,
that's the residual from the base of the
right,
second metacarpal.
from the base of the second metacarpal. So you go thumb metacarpal first, then you put it into the index, and you've got this long extra suture tape, and you're taking the free needle that is already in the package, and you're taking it going from the dorsal base of the thumb metacarpal.
Yeah, I think you can go either way. I don't think it matters, but you're basically pushing the needle through the bone. I go from from what used to be the articular surface of the metacarpal through the dorsal bone of the metacarpal, and then pull it back down onto itself.
And then how do you tie that back to itself?
You
Tie
tie
it to
it.
the whatever the bridge is?
Yeah, you tie it to the bridge. It's easy.
Okay. I haven't thought about it that way. And, is that something you do for everybody?
Um, I would say I do it for half the patients. If there's any inclination that that metacarpal is not going to be stable, I go ahead and do it because there's no downside. The only potential downside is you creating a bulky knot. But if you try to keep your knot down, it doesn't cause a problem.
How would
Um,
you handle that if you say, for example, were in the real world and couldn't spend $8,000 on a thumb CMC surgery?
I think in that
It's
case,
not $8,000,
no,
but
no, it's definitely not. In that case, it's about your tunnels, and if you're doing an LRTI, really, the LRTI should allow you to control that base of the metacarpal. And so, if your drilled tunnel really goes from dorsal to volar, and you pass your FCR tendon really from near its insertion to the base of the second metacarpal through the metacarpal, and bring it back on itself, it should accomplish the same goal,
Yeah.
which is really magic when it happens. It's very cool.
Yeah, no, absolutely. And that's how I would I haven't done a true LRTI in a while. But that is the technique that I learned from mainly Dr. Gelberman. I remember doing a lot of LRTIs with Dr. Gelberman and having a lot of anxiety because every step had to be perfect.
Yeah, yeah, absolutely. And the reason there's obvious, this makes sense. If you can avoid that second surgery at the MP joint, obviously that's great. Um, when I think about the MP joint, there's a few operations I think about. One, just pinning it, which I don't think makes much sense, even though I've been guilty of doing that because I don't want to do more. You can do the volar plate advancement, which I've never been thrilled with. I think a soft tissue procedure there, if you haven't balanced the forces, doing a soft tissue procedure like that is doable, but doesn't always give you the results you want. And then the fusion.
Well, what
Um,
about what before fusion? What about I've seen people talk about EPB tenotomies or tendon transfers. Any experience with that?
I, you know, I don't understand the EPB. I don't understand its insertion. I think it sounds straightforward. The EPB inserts in the dorsal base of the proximal phalanx. It doesn't always, um, and you can get an extension lag, but I don't have a lot of faith in the EPB. I do think it probably is a deforming force. It's hyperextending the joint. I've never done an EPB tenotomy or transfer. Have you?
In training, I saw it at in residency. There was a surgeon in residency that would do this routinely for basically they would transfer the EPB and over to the APL for pretty much every thumb CMC surgery. Now, I'm not sure that's what works for me, and I don't know how much of that was a billing thing too, because you could bill for a tendon transfer. Can't believe I said that. But one of the fellows at that point, because I asked the fellow that I was working, I was like, "So, what's the deal there?" And they're like, "Oh, it's a billing thing."
Oh man. Well, it does raise the question of, do you release the APL from the base of the metacarpal when you treat the CMC joint?
I mean, I guess conceptually, yes, that would make sense, but not anything that I've done.
Yeah.
So like, so when do you ever fuse the MP joint? Because this has come up for me recently in some crazy deformities.
Well, it's obviously much easier if you have arthritis at the MP joint. And certainly that happens. And then you should just go ahead and fuse it. And to reiterate this, we've said this on the podcast before, but for the younger listeners, um, when there have been studies looking at the utility of different procedures, and the citation I'm about to provide is regarding rheumatoid arthritis, but it doesn't matter. One of the best operations you can provide to a patient in hand surgery is MP joint fusion of the thumb. It's a great operation. It takes care of alignment, it takes care of pain, and there's very little morbidity to doing it. So you shouldn't hesitate if there's an indication, and arthritis is a great indication. Instability is a reasonable indication, but I offer it if I don't think I can control the metacarpal posture through the CMC joint. And that absolutely happens. And it's a vague answer because I think it has to be a vague answer.
Is that an intra-op call? Because that kind of
It
messes with your surgery scheduling, right?
it does, but thankfully it's a quick surgery. It's a quick addition. I think you have to consider that option when you meet the patient in the office. And I'd rather have them expecting that and my doing it rather than not expecting it and my feeling like we needed to do it. So if you don't think about it early, you're not going to think about it later. So you should always think about it in the office. And then I do think it's an intraoperative call, although generally my mind's made up beforehand because I know what we can accomplish at the CMC joint.
So when you fuse it, flex it, and do you do a little bit of flexion? How do you like to do that technically?
Yeah, I like a tension band technique because, like everything, Chris, is inexpensive. It's not $8,000. And I tend to put a little flexion in 10 to 20 degrees. What do you do?
A little bit of flexion. You're gonna laugh at this. Headless compression screws. I like
Oh
it.
my God.
Spend some money. But to me, that I think that the K wires can be a little bit futzy at times. Tension banding, I think, does work well. But essentially, I'm using the headless compression screws as internal struts, not necessarily in this patient population. You have the best bone, and so you're not looking for tons of strong compression. But it's a nice way to have an implant in there that's not going to be prominent, but holds it in place.
That's very fair. And I haven't done that. we were in Pete's conference on Friday morning, and one of my partners was talking about doing putting a dorsal plate on a distal 1/3 of the radius fracture, because if he doesn't show residents how to do it, no one's ever going to show him. And I think tension bands are really a wonderful orthopedic technique that is slowly disappearing from,
Right,
you know, from training. And so
right.
this is a great, reliable way to use it. I use it for PIP joints as well. What do you do for PIP joints?
I'm honest with you. I would use the tension band, but I haven't fused a PIP joint in a long time. So, uh, I think I did one early in practice, but I can't remember the last one I did, to be very honest with you.
You're probably not missing them either.
Yeah, yeah. Well, if it makes you feel better, maybe I'll slide some stainless steel wire through the cannulated portion of the headless compression screw and
Nice.
tension band it that way. Complete orthopedic window dressing because it won't do anything. But
The 2022 tension band technique
yeah. No, I
by
think I
Dr. D.
think I agree with you. Tension banding is important, and it's a technique that we don't use enough anymore. Just because I think that the younger generation of surgeons thinks of other options first. So I think if you have the opportunity to teach it, fantastic. And same thing, honestly, I feel the same way about dorsal plating for distal radius fractures. Oftentimes do it just so people can see it being done.
Yeah, for sure. For sure. All right. It's been fun. I like talking about this kind of stuff.
Yeah,
Yeah, it's good.
it was great. Go enjoy your congenital journal club. I'm gonna go help a friend move.
Oh my God. Tell Marshall I said, hey.
Exactly. All right.
Take
Talk to
care.
you later. Bye.
Bye.